Hello, I'm Dr. Bianca Santomasso, Assistant Attending Neuro-Oncologist at Memorial Sloan Kettering Cancer Center. Today, I will be discussing the characterization and general management of neurotoxicities associated with immunotherapies, including definitions, symptoms, timing and pathology, grading for adults, and recommendations for management. Specifically, our discussion will be focusing on neurotoxicities associated with CAR-T and bispecific antibody use. Immuno-oncology therapies are associated with neurologic adverse events affecting the central and peripheral nervous system, including encephalitis, neuropathies, demyelinating diseases such as Guillain-Barré syndrome, and neurodegenerative disorders such as Parkinsonism. Some of these therapies, CAR-T and bispecific antibodies, may lead to serious and life-threatening neurotoxicity. The most common type of neurotoxicity associated with immune effector cell therapies, such as CAR-T and bispecific antibodies, is immune effector cell-associated neurotoxicity syndrome, or ICANS. ICANS is a pathologic process that may occur after any immune therapy that results in activation or engagement of endogenous or infused T cells and/or other immune effector cells, and that subsequently involves the central nervous system. ICANS is thought to be caused by immunotherapy-induced activation of the immune system. This includes activation of immune effector cells such as macrophages, as well as the release of pro-inflammatory cytokines from the tumor site. In ICANS, these pro-inflammatory cytokines released at the tumor site may leak into the vasculature and travel throughout the body. Once pro-inflammatory cytokines reach the brain, they are thought to disrupt the blood-brain barrier and cause neuronal cell injury within the central nervous system, leading to neurotoxicity associated with immune effector cells. Cytokine release syndrome, or CRS, can be a life-threatening or fatal adverse event of immune effector cell therapy. ICANS typically occurs concurrently or after CRS. Not all neurotoxicity symptoms in patients treated with immune effector cell therapies are associated with ICANS. Symptoms consistent with ICANS include aphasia, altered level of consciousness, agitation, delirium, seizures, encephalopathy, cognitive skill impairment or difficulty concentrating, and motor weakness. Neurotoxicity symptoms not included in the definition of ICANS are headache, tremor, myoclonus, asterixis, hallucinations, peripheral neuropathy, and Parkinsonism. Peripheral neuropathy and Parkinsonism have been reported very rarely with some CAR-T products and may have a later onset than other symptoms, so patients should be monitored appropriately. Also of note, this list does not encompass all symptoms, and additional manifestations should be considered. Certain patients may be at higher risk for developing ICANS after immunotherapies. Some clinical factors associated with ICANS include patient and therapy-related factors such as age, high disease burden, pre-existing neurologic comorbidities, and autoimmune diseases, CRS onset and severity, and therapy dosage and/or combinations. Evidence suggesting that autoimmune diseases are patient-related risk factors is specific to checkpoint inhibitors, and currently there is not enough evidence to suggest autoimmune diseases as a risk factor in treatment with immune effector cell therapies. Biomarkers such as LDH, CRP, fibrinogen, and ferritin may be used to identify patients at increased risk for ICANS. However, there are no set guidelines for ICANS diagnosis based on biomarkers, and biomarkers are usually considered in addition to other patient or therapy-related clinical factors, such as disease burden and type of therapy. ICANS also varies in severity. Common terminology criteria for adverse events version 5 or CTCAE version 5 grading is used to evaluate all neurotoxicity. The American Society for Transplantation and Cellular Therapy recommends using the ASTCT consensus grading for grading of ICANS and CTCAE version 5 to grade events that are not part of or consistent with the ICANS definition criteria. Using this framework, Grade 1 ICANS, shown here, is characterized by an immune effector cell-associated encephalopathy, or ICE score, of 7 to 9, ability to awaken spontaneously, and no presence of seizure, motor findings, or elevated intracranial pressure or cerebral edema. Patients experiencing grade 2 ICANS also have no presence of seizure, motor findings, or elevated intracranial pressure or cerebral edema, but they have an ICE score of 3 to 6 and may need vocal prompting to awaken. Patients experiencing grade 3 ICANS have no major motor weakness such as hemiparesis or paraparesis, but have an ICE score of 0 to 2 and may require tactile stimulation to awaken. Patients are classified as experiencing grade 3 ICANS if they experience any focal or generalized clinical seizure that resolves rapidly, experience a non-convulsive seizure on electroencephalography that resolves with intervention, or have focal or local edema on neuroimaging. Finally, patients who are unarousable or who require vigorous, repeated tactile stimulation to arouse, and for whom the provider is unable to perform the ICE assessment, are classified as grade 4 ICANS. Patients experiencing grade 4 ICANS may experience life-threatening prolonged seizures of over 5 minutes or repetitive clinical or electrographic seizures without return to baseline in between, have deep focal motor weakness such as hemiparesis or paraparesis, diffuse cerebral edema on neuroimaging, decerebrate or decorticate posturing, cranial nerve 6 palsy, papilledema, or Cushing's triad. Management of ICANS differs by grade and by whether ICANS is experienced concurrently with CRS. Patients treated with immunotherapies require monitoring for signs and symptoms of ICANS. For most patients, symptoms of ICANS occur in the first month following initiation of treatment. However, some neurotoxicity symptoms may have a later onset and require prolonged monitoring. Consider monitoring the following symptoms: impairment of motor function, such as handwriting changes, changes in sensations, such as numbness, headache, speech disorders, convulsions, disturbances in consciousness, confusion, and disorientation. Clinical evaluation of ICE scores and motor sensory evaluations, along with patient caregiver monitoring for handwriting, personality, or gait changes for up to 6 months, could help identify prolonged neurotoxicities which are not recognized as ICANS. Laboratory testing may also be helpful for monitoring ICANS and other neurotoxicities. Consider the following diagnostic tests: serologic testing, magnetic resonance imaging of the brain, lumbar puncture, electroencephalography, and electromyography. Management of patients experiencing ICANS is often based on established guidelines and requires coordination between the patient, caregivers, and multiple healthcare providers, such as referring oncologist and the administration team at the care center. Multiple versions for ICANS management have been implemented in clinical trials with interventions as per the investigator's discretion. Given the onset of ICANS in relation to CRS, guidelines have included management based on CRS manifestations in addition to toxicity grade. Consider partnering with a neurologic specialist to discuss supportive therapy and ICU requirements. Overall, strategies for management may begin with determining the grading of ICANS and CRS if applicable. The type of immune effector cell therapy should be considered to determine whether withholding of the therapy is needed. Pharmacological interventions may be needed. Shown here are select pharmacologic management strategies for ICANS from established guidelines. For ICANS without concurrent CRS, consider administration of non-sedating anti-epileptics and/or corticosteroids. For ICANS with concurrent CRS, consider administration of non-sedating anti-epileptics, corticosteroids, and/or anti-cytokine therapy. However, it is important to note that anti-IL-6 receptor cytokine therapy is not indicated for ICANS alone, and in some cases may worsen ICANS. For ICANS with concurrent CRS, ICANS and CRS grading should be considered to determine the potential use of anti-cytokine therapy. If CRS grading exceeds ICANS grading, anti-cytokine therapy may be recommended, but anti-cytokine therapy should not be considered for ICANS only. On the contrary, if ICANS grading exceeds CRS grading, corticosteroids may take precedence unless manifestations of high-grade CRS. Then anti-cytokine therapy co-treatment should be considered. Supportive care for ICANS and CRS should continue until symptoms are reduced to grade 1 or less. For more comprehensive guidance on supportive care related to CRS and neurotoxicity management, refer to your institutional guidelines and established guidelines, such as from ASCO and CITSI, as well as product prescribing information. To learn more about characterization and general management of adverse events associated with anti-multiple myeloma treatments, please visit jansenscience.com.